following the travels of one of our faculty people here who I think showed up in the hotel about 5 minutes ago from San Diego. I've been hearing this story, Rana.
I made it.
You're here. Awesome. So really thrilled that you're able to make it. Emmanuel Antonarakis also here. Susmitha Apuri from the Florida Cancer Specialist, another doc who's been nice enough to present cases to us over the last couple of years. So we're going to talk about prostate cancer today. We're going to start talking about hormonal therapy, and then Dr. Antonarakis is going to pick up on some other treatment strategies. But just before we start talking about data, maybe just to talk about sort of patient care issues. And I guess hormonal therapy has undergone a whole lot of changes in the last few years. And this past year, even more so, and Rana, you're going to talk a lot about that. But maybe I always like to think a little bit macro. So one of the things that we've seen in prostate cancer is a movement toward endocrine therapy intensification. So first we started to see that with metastatic disease, then biochemical, now even with localized disease. Can you talk a little bit more about that and the thinking behind that? And like nowadays, in what situations you use LHRH alone?
Yeah, no, that's a very good segue here. I think the backbone of treatment for prostate cancer has been suppression of testosterone to generate a castrate environment within the tumor, essentially to mitigate prostate cancer growth and progression. And what we've actually been realizing is the better we do that in higher risk tumors, the better patients do. In every single setting where we've escalated hormonal therapy and more potently mitigated androgen signaling, again, in high-risk individuals, we've improved outcomes. We've done that in the metastatic castration-resistant setting, pre and post chemo. We've done it in the MHSPC setting. We've now done it in the biochemical recurrent setting for high-risk individuals, and now also localized. But I think the key is high-risk individuals. Yeah.
And, you see the same principle in breast cancer in terms of hormonal therapy. If you add LHRH to a premenopausal patient, they'll get greater benefit than, say, tamoxifen alone. And Susmitha, in a second, I'm going to turn to you, see if you have any questions about hormonal therapy. But I want to go back to Emmanuel again in terms of this trend to intensify therapy, because on the other side, you may have more symptoms, more tolerability issues. Can you talk again about, sort of what are some of the combinations that are being used right now and some of the tolerability issues you have to deal with?
Neil, never before has there been a time that we had to talk about risk and benefit more carefully with our patients, because the doctors on this stage and in the audience even might be loving the combination data, but the patients don't love it. And what they don't love about it is the toxicity. So we're telling them that they're living longer, but they're not necessarily living better. They're having more metabolic side effects, bone health side effects, fatigue, cardiac side effects. And the question that the field has not answered is, can we intensify but then shorten the duration, or do we have to intensify and continue for life? And patients would like us to answer the question about augmenting the therapy and then stopping it earlier.
So there are a few general questions I'd like to kind of get into, at least some of the things, again, I hear a lot of questions about. But first I want to go to Susmitha and any questions you have.
I think the big question is when we see these patients, they come from our urology colleagues, and they tend to use a lot of LHRH antagonists. And we tend to, or at least my practice is to use an agonist like leuprolide. Do you have any preference? Is there a difference in efficacy between these medications?
Yeah.
And also the oral agent, which is an antagonist, relugolix. So, Rana, any thoughts?
Yeah, I'm more than happy to take that on. I think from an efficacy level, we haven't necessarily seen that an antagonist is more efficacious than an agonist. Mechanistically, you may think that it may be, but I think it hasn't really panned out in the data sets. I think there's this evolving notion around the cardiovascular risk reduction with an antagonist that seems to be driven by further augmentation of LH and FSH. But really what we've come to see from data from Pronounce and other studies is actually if you appropriately risk modify and are aggressive about prevention, it kind of doesn't really matter what agent you use. From the Pronounce study, patients getting both an LHRH agonist versus an antagonist all had aggressive cardiovascular, prevention. They were seeing a cardiologist. They were getting their lipids checked. They were getting their blood sugars checked. And at the end of the day, the event rate was really low in both arms, and there was no difference. And so I think that, if the message really is being preventative, and a drug isn't going to save you from a cardiovascular event in the absence of prevention.
Before I go back to Susmitha, how much of an increase in risk is it to have, for example, an LHRH agonist? How does that vary based on the patient's age? And what do you actually recommend to your patients, Emmanuel, specifically?
Yeah, the increased risk appears to be only in those patients that have had a prior cardiovascular event already. In patients that have never had a heart attack or stroke, there doesn't seem to be an increase in risk. In those that have had one or more prior strokes, the chance of having a second one is about 20% versus 10%. The last thing I'll say, and I'll say it briefly, is that there's no question that when you stop the oral agent, the relugolix, testosterone comes back faster. So if your goal is intermittent therapy, finite course, and then recovery of testosterone, that's the better choice. But on the other hand, we don't have good data on combinations. So if you plan to combine your ADT with apalutamide or enzalutamide or abiraterone, that's where we don't have the robust large-scale data to do that.
Any other questions, Susmitha?
Is there a difference in the side effect profile, and what would be the role of bicalutamide? I still see that used quite a bit in the community. So where does that play a role in these agents?
Rana?
Yeah, I'm more than happy to take that on. The side effect profile, I don't think they're too different. I think they're fairly equivalent with regards to hot flashes and fatigue and the side effects that the patient feels. When we think about bicalutamide, I think where I'm seeing it utilized in clinical practice now is really to prevent there being a testosterone surge with a LHRH, agonist being utilized. But really outside of that, we're not really doing too much combination ADT bicalutamide. Like in the individuals that I would give combination therapy for, we've demonstrated in those different subsets, like localized high risk, getting radiation and hormones, or biochemically recurrent, getting hormone therapy that's high risk. Like we're escalating with a next generation AR antagonist. So I don't really see a huge role for bicalutamide in the modern era.
So again, Raina's going to go through the data, but I just want to jump right into some of the controversies. And one of the things I find a little interesting is how you all approach hormone-sensitive metastatic disease. And of course, we've seen a bunch of phase 3 trials now, amazingly, in all stages of prostate cancer, now LHRH is considered, you cannot do that alone in 95% of the patients. It seems like you have to add on some type of AR, antagonist. I'm curious which one you prefer. But Emmanuel, the big question that I have a hard time understanding what people do about is whether you use docetaxel. So tell them why I'm confused.
Well, because it's confusing. I think what we know is it is currently incorrect to use ADT and docetaxel by itself. It's not at all incorrect to use ADT plus one of the 3 novel hormone therapies without the triplet. So if you are really opposed to using the triplet and your patient is opposed to it, you don't have any conclusive evidence that ADT plus abiraterone or ADT plus enzalutamide is inferior to that combination plus the docetaxel.
Again, Susmitha, any questions? How much experience have you had with the 3 androgen receptor signaling agents? And we hear that darolutamide is better tolerated. Do you have any experience and thoughts about that?
I do. In my practice, I have used abiraterone the most, followed by enzalutamide. I think only because of how the drugs have been approved. I did have one patient who received darolutamide, but only for 6 weeks and developed hepatitis. and that was my N is equal to 1. And I think every time I try to think about the medication, obviously it comes into play.
So Rana, can you kind of put this in perspective? And, again, you hear people saying you only have indirect comparison. Darolutamide is better tolerated. A lot of people use enzalutamide. People use apalutamide. Any thoughts?
Yeah, I think that there are some subtle differences across the AR antagonists. They're probably more similar than they are dissimilar, but there are subtle differences. And I would put abiraterone in a bucket of its own because abiraterone is a CYP17 inhibitor that actually drops testosterone levels and can induce, castration, whereas the AR blockers alone are non-castrating. They're AR blockers. I think enza and apalutamide formula-wise, they're very similar, structurally similar compounds and tend to have a similar side effect profile. I would probably say that enzalutamide has a little bit more fatigue. There was an increased risk of falls and seizures in some of the earlier studies. There's more drug-drug interactions that are associated with enzalutamide. With apalutamide, one of the things that can happen that's unique is rash. It's not to say that it can't happen with the other agents, but we saw higher rates of rash with apalutamide, but tends to be well managed with just supportive therapies and being proactive and informing your patients about it. Darolutamide is structurally distinct from enzalutamide and apalutamide in preclinical models, so none of this has been done in humans. There's been less penetration into the CNS, and so that's where there's lower rates of falls and lower rates of fatigue that seem to almost be on par with the control arm in many of the studies. And so I think that's where darolutamide gets its reputation that it's a better tolerated drug. There's less drug-drug interactions with darolutamide when you kind of pin them against like the list with enzalutamide and others. So you just have to be careful about that.
So I'm going to go down to localized disease because, again, Emmanuel, we're hearing about intensification of therapy, particularly in high-risk situations. So, for example, locally advanced disease, in the past we've used radiation therapy plus LHRH agonist. Are we intensifying there?
We are intensifying based on the STAMPEDE study. It's a bit of a messy study, real-world evidence in a way. It's basically the entire UK population that was participating. One aspect of that trial was the use of ADT for 2 years plus abiraterone, also for 2 years with prednisone 5 milligrams once daily in patients that I consider to have ultra-high risk localized or locally advanced disease. And these were patients that primarily, the vast majority of them were going to get radiotherapy to the prostate gland as their primary definitive treatment, plus 2 years of ADT plus abiraterone versus the same without the abiraterone, and there was a survival advantage and a metastasis-free survival advantage. So in that setting, the very strongest evidence to date is to add abiraterone for 2 years with prednisone 5 milligrams once daily and then stop after 2 years.
And if for some reason you don't want to use abiraterone, would you be okay using an anti-androgen?
I wouldn't because I'm a purist, but I'd like to see what Rana would do.
I probably would, actually. These patients had a PSA of greater than 40. They had to meet the ultra high risk criteria were PSA greater than 40, stage 3 disease, or Gleason 8, 9, 10 cancer. Had to have 2 out of the 3 of those. And I think this was not, these patients didn't have PSMA PET scans, didn't have any data like that. And the utilization of even prostate MRI for staging wasn't broadly utilized. These were like clinical T3 disease patients, which I think in our practice, not to say we don't see anymore, we're detecting a lot of these higher risk tumors on MRI. So I think, had these patients had additional imaging, and there's a lot of controversy about upstaging just based off of imaging, I think there's enough data to say these people need more than just ADT alone. And the way I approach it is these are patients with localized disease with getting curative intent therapy, and this is my last attempt to cure them, my first and only. I got 1 shot. So I like to escalate. So if there's somebody that for some reason cannot get Abby is my preferred agent, I think in this setting. If they cannot, then I do, understanding the limitations of the data.
So again, before Rana jumps into the data, I'm just going to say, Susmitha, were telling me about this 80-year-old man Gleason 5+5, treated with radiation therapy, then had a biochemical recurrence. It looks like a pretty complicated case. Can you just maybe throw out a few general questions to Emmanuel in terms of how he's thinking through the patient with biochemical recurrence? And particularly, and Rana's going to go into this, amazing study that was presented last year, the EMBARK study, my favorite study of the last year in oncology, period. What an incredible study. But any questions, just to get warmed up, you want to throw out to them about biochemical recurrence?
I think the big question is when you know that they belong to a high grade, high PSA high, grade group high, we know that they're going to reoccur. I think the big question I have is there any way that we can do a prevention strategy here when we know these patients have a high risk of reoccurrence already? And is there a preferred agent for you? We talked about abiraterone in these high risk, like do you try to use abiraterone versus enzalutamide? Like do you go to a specific drug saying that, gee, okay, this patient is a high risk patient?
So we'll try to make it real quick, and then Rana can do the data, and then we can really hopefully have enough time to really jump into it. But bottom line, this 80-year-old person, high risk of a recurrence, Emmanuel, that you want to treat, what's your most likely therapy?
So we don't have data for adjuvant, so you have to wait for the biochemical recurrence.
I think she's saying is biochemically recurrent, right?
Well,
Now it
she was
is,
kind
but
of
yes,
asking
the
about
original
adjuvant
question
too,
was
reading
to
between
prevent.
the lines.
Okay.
So you have to wait for the biochemical recurrence. Gleason 10, 20% of those will be cured with local therapy. So the key points are make sure the doubling time is rapid. If the doubling time is super slow, like doubling time of 24 months with a Gleason score of 10, I wouldn't jump into it. And PSA should be, a measurable number. Don't do it when your PSA is 0.002.
So doubling time is 6 months.
Less than 9 months. Yeah.
All right, but I'm saying if the patient, let's say, what's your therapy?
It would be ADT plus enzalutamide. Try to stop after 9 months if there's a PSA 0, and then restart if there's a recurrence.
So intermittent ADT and enzalutamide, something we hadn't heard a whole lot about. And in addition, now you're going to hear about intermittent enzalutamide monotherapy, which we never heard about. Rana, take it away.
All righty, so we're gonna dive right in, talking about the role of hormone therapy, highlighting some key studies. We're not gonna go through all of the data, it's just too much. Here are my disclosures. So we'll start out with a clinical case. Similar to some of the cases we've been discussing today, a gentleman with an elevated 70-year-old man with an elevated PSA on routine screening, PSA 7, had an MRI done, found to have a PIRADS 4 lesion with capsular abutment, had a biopsy, he's 3+4, had ended up undergoing a radical prostatectomy, confirming the 3+4 negative margins, and actually ended up having T3B invasion with some pathologic seminal vesicle involvement. He was followed for a period of time and then developed a biochemical recurrence. His PSA went up to 2.2. And I think there's a lot of sort of, not say controversy, but this is an area where there's a lot of gray, like how high do you let the PSA go? When do you scan? Is 0.2 too low? 0.3, 0.4, what do you do? So he did end up undergoing a gallium PSMA PET scan at that point in time and was found to have an avid external iliac node. Also ended up having an MRI, which confirmed the node, which you can see there. And then actually he went on one of our clinical trials, went on the Formula 509 trial, which we're going to talk about. This was a trial of intensified therapy for patients getting salvage radiation treatment. Unfortunately, despite him doing salvage therapy, he later developed, 2 years later, developed a biochemical recurrence. PSA rose up, higher now, 0.89 with a doubling time of 6 months. And he did undergo a PSMA PET scan, which was negative, and we started him on treatment with intermittent enzalutamide and leuprolide. And understanding this case is unique because this gentleman has been exposed to prior ARSI with the abiraterone and apalutamide from Formula 509, but he's got pretty aggressive disease.
Could I just ask how you did the intermittent therapy with him?
How we did it? 9 months of Lupron. Actually, we ended up doing 9 months of Lupron. He got 3 months injections and started the enzalutamide. And, I think sometimes we get all caught up on the flare. Usually what I'll do is I'll start their Enza first. Just go ahead as soon as you get the Enza, start it, and then we'll bring you into clinic and get your injection. And so then you don't even need to mess with the biclutamide. Like I don't use biclutamide rarely in my practice.
And then you stop at 9 months if their PSA is undetectable. But now, will you retreat when it comes back up?
Yeah, if he, we're still following him, but if he were to have, we would anticipate that he's going to have another biochemical recurrence. And when he does, I'm going to treat him again with doublet enzalutamide.
And again, are you going to consider stopping?
Yes, unless he develops metastatic disease.
All right, let's talk about the data.
All right, so diving in here, we've talked for the different clinical states of prostate cancer. We've got clinically localized disease, where that's your opportunity to be treating the bulk of these patients with curative intent therapy. Obviously, a lot of patients can undergo active surveillance, but those patients that need treatment either undergo surgery or radiation. There's really no role for adjuvant therapy at the present time. There's a lot of trials that have been conducted in the adjuvant setting, and it's really hard to enroll onto adjuvant studies of prostate cancer. They've largely failed because of slow accrual and issues with getting patients on. Nobody wants to go on hormone therapy when their PSA is undetectable and they just had surgery, though there are studies that are being done. And then, of course, there's the salvage setting where there is another attempt to cure, particularly for those individuals that have had a radical prostatectomy going on, doing radiation, and depending on their risk factors, their PSA, their rate of rise, adding hormonal therapy to the radiation. And then for some people, they do end up developing a biochemical recurrence despite their definitive local therapy, and they're no longer candidates for local treatment. That's termed biochemically recurrent disease. And then, of course, our clinical states of clinical metastases, when the individual is still hormone sensitive, or they can have a rising PSA when their testosterone is really low. I think this disease state is ever decreasing with the advent of PSMA imaging, and then kind of end-stage prostate cancer, kind of lethal prostate cancer, is metastatic CRPC. And so PSMA PET has definitely impacted how we think about staging, and there's been a lot of stage migration as a result of PSMA PET, but I want to keep clear that a lot of these studies that were done with conventional imaging and direct application for somebody that's had a PSMA PET scan should be done very carefully. All right, we've kind of hit that home. So these are a lot of treatments have now populated the treatment landscape. Before it was just like ADT alone, but you can see a ton of different agents in the NMCRPC setting. Well, I'll start at the beginning. So now we've got abiraterone added to local disease. We've started to talk about some of that data from Stampede. In the biochemically recurrent setting, we've got enzalutamide from EMBARK that's been added into that, again, for those individuals that have high-risk disease. In the NMCRPC setting, we've got the AR antagonist, APA and Zadara. And again, more similarities across these studies from an efficacy standpoint than these agents being dissimilar. And then in the MHSPC setting, we've got your ARSIs, ABI, ENZA, APA have been approved in this context, and then the combination therapy of dosi-ABI and dosi-darolutamide. And then a lot of agents in the MCRPC setting. We're not really going to talk too much about the MCRPC setting in this talk, but a lot of agents with different mechanisms of action, and it's exciting to see those available for our patients. So let's talk about the EMBARK trial. The EMBARK trial was a clinical trial that was conducted for patients who had biochemically recurrent disease that had undergone definitive treatment, whether that be radical prostatectomy or radiation therapy. Screening PSA had to be one. They had to have a PSA doubling time of 9 months with no evidence of metastases on conventional imaging. And patients were randomized 1:1:1 to receive the triplet of enzalutamide plus Lupron, given on an intermittent basis for 12 months, placebo plus Lupron. And then they also had an unblinded kind of exploratory arm of enzalutamide monotherapy. And I think it's important to sort of understand that this enzalutamide monotherapy was an unblinded cohort, and the other two were kind of randomized. And the primary endpoint of the study was MFS by independent review, and this was MFS as defined by conventional imaging. A key of secondary endpoints were looked at in the context of this trial: time to PSA progression, OS, and other really important things, safety, quality of life, which we'll talk about. So this was a positive trial. in this high-risk population, the addition of enzalutamide to the backbone of ADT improved metastasis-free survival and also improved PSA progression. And you know what's interesting when I look at these curves, look at that PSA progression curve, look at the flat line for the combination, and then juxtapose that with the MFS curve, which tells me that there's some people that are progressing with an undetectable PSA. And so, like, you know, that PSA progression curve is pretty flat, okay?
We call that a pelican graph, incidentally. Matt Smith gave that name.
Yeah, oh, nice, I like that.
Pelican, with his mouth open.
Well, see, we're in Florida, so this is very befitting, okay? And I actually grew up in Florida. I went to school at the University of Florida. So I love when Kaplan-Meier curves look like a gator chomp. I've said this before. It's just like, that's like a beautiful Kaplan. It gets wider and wider and wider as you get farther away from time zero.
That was actually at the FCS retreat that happened.
I should overlay
graph.
A nice, like, UF Florida gator there.
No, we have one like that.
Okay.
On that graph.
Okay, I think March Madness is going.
You're
I
right,
heard
exactly.
something about a game yesterday that didn't go very well. All right, so and then this is the data for the monotherapy arm. Again, this was an exploratory kind of secondary analysis, and compared to just ADT alone, and there was an improvement in MFS with monotherapy compared to Lupron. The hazard ratio here was 0.63. But again, keep in mind, we're not comparing here enza-lupron to mono. You know, we're kind of just doing a 2x2, like a 1-to-1 comparison, as opposed to actually comparing all three and looking at all three and saying which of all three is better than Lupron alone, or Lupron, I should say. All right, then there was some really nice data presented by Steve Freelander at ESMO last year, looking at quality of life from EMBARK. And I think the key take-home message here is that there was really no decrement in quality of life when you look at the combination versus Lupron alone. And when I look at the monotherapy, I know the monotherapy is getting a lot of like patients feel better on the monotherapy, like barring the sexual side effects, like the monotherapy data is on par with Lupron. So I think the biggest thing that we kind of gain is the sexual improvement of sexual side effects, but that's really it. And I think you do have to contend with the gynecomastia. They did not kind of mandate prophylaxis for the gynecomastia in the context of this trial.
Do you bring it up to your patients as an option?
Oh, 100%. I tend to not necessarily use enza monotherapy unless I've got somebody who's really has some contraindications or is just refusing to go on ADT.
And Emmanuel, if they say, will my sexual function be better if I take enza monotherapy and get my breast radiated?
I tell them it'll be a little bit better, but you're going to regret it because your breasts are going to get bigger and they're going to be painful.
And if you do one dose of radiation,
it does help.
Help or prevent the problem?
It doesn't prevent completely, but it helps a lot.
Yeah.
Please continue.
All right, so then here's actually the, additionally the quality of life and side effect data and AEs of special interest. And I just, again, want to kind of draw the attention to the hypertension piece. Most of this is on par, slightly worse with the combination therapy. But when you look at the hypertension and you look at the monotherapy, the rates of hypertension with the monotherapy and the combination are actually on par with one another, 21.8% versus 25.2%. So I think, when you look at the monotherapy profile and you look at the combo profile, they're not actually that dissimilar. And so I think we just need to be honest with ourselves and honest with our patients, what we're achieving. And when we look at the quality of life data, again, these patients were not blinded. They knew they weren't getting injections. They knew they were only getting ADT or enzalutamide alone, and that impacts how somebody fills out a survey. All right, so then I do want to highlight the Presto study. I know I'm coming up against it here. Gosh, I can't believe we're already eating up time, but this was a study also done in the biochemically recurrent setting for patients that had relapse prostate cancer, post-radical prostatectomy. They had to have a PSA of 0.5 or higher with a doubling time of less than 9 months. This was a study done through the cooperative groups looking at the combination of APA with an LHRH analog or APA-ABI with an LHRH analog. The primary endpoint for this study was biochemical progression-free survival, so not as robust of an endpoint as MFS. It was a positive study for both the comparisons of LHRH analog plus APA compared to LHRH alone, or the triple, but the toxicity profile of the triple and the degree of the effect, the benefit from the triple was actually a lot lower. That I think the messaging here is really around the apalutamide. And then we began to talk about the triple therapy strategies, PEACE-1 and ARASENS. So I think just to give a little bit of context, ADT was the backbone of therapy for MHSPC. In the context of some of these studies, particularly PEACE-1 being conducted, docetaxel became the new standard of care because of the CHARTED study and STAMPEDE, and the control arm needed to be modified to account for the fact that docetaxel became the standard of care. And ARASENS was getting designed right around the time that docetaxel was getting approved in the MHSPC setting. And so the control arm in these studies became the new standard of care of the time, which was ADT docetaxel. So as Emmanuel was saying earlier, we don't have data on just ADT and an ARSI, though hopefully that will come in the future. There's a study through the cooperative groups that's currently being planned to answer that question. So PEACE-1 was a positive study. The combination of ADT and abiraterone and docetaxel did improve outcomes for patients, but the benefit was particularly seen for those patients that had high volume disease. When we look at the ARASENS data, we saw an improvement in both low risk and high risk. The low volume patients, you can see the curves kind of overlapping, but in both low and high risk. The difference between the volume and risk definitions is the risk definitions refer to the Latitude clinical trial. The volume definitions refer to the CHARTED clinical trial. But there's data from ARASENS that in a lower risk group, patients actually do benefit from an escalated ARSI, which has kind of become the standard of care. And so these are all the different factors that impact clinical decision-making: disease factors, clinical factors, drug factors. These are the data for the high volume risk disease. I don't want to belabor it, but the docetaxel data, the ARSI data, and then also the role of radiating the primary in the MHSPC setting. No role for high volume does seem to benefit patients with low volume disease. And across the board, looking at the ARSI data, definitely a benefit for both low and high volume disease. The doublet therapy with chemotherapy is really no longer a standard of care given PEACE-1 and ARASENS. And then here's just sort of the difference between the definitions, volume and risk. And this is all conventional imaging. PSMA PET can't apply this definition. It doesn't exist. All right, and there's a lot of concordance between the high volume, low risk, and or high volume, high risk, and low volume, low risk definitions. All right, and this is, we'll kind of skip that. And then other clinical factors to consider, this is just the side effect profile of the different agents. Abiraterone, you have to contend with the mineralocorticoid excess, the AR antagonist with fatigue, falls, rash, hypothyroidism, drug-drug interactions. And then the antagonist, we talked about the CV risk, but also I like to use an antagonist if somebody needs an immediate drop in their T, they can't afford the flare, they're obstructed, and they've got MHSPC or cord compression. And so we've really totally changed the treatment landscape of hormone-sensitive prostate cancer with the escalation of ARSIs and more advanced hormonal therapies to intensify treatment. And Emmanuel's done a lot of work on other hormonal agents, CYP11 inhibitors, and others that are going to probably make a break in the near future.
Yeah, we were tackling all the new wild agents in breast cancer last night, including some I think they're going to be looked at in prostate cancer as well. Emmanuel Salmon from the audience here has a patient with metastatic disease, 80-year-old patient presents with metastatic disease, no prior therapy, high volume disease, and a de novo ARV7 mutation. How often do you see that, and does that change what you do?
That's pretty bad, less than 5% of the time. If he was fit for chemotherapy, I would offer him triplet. Just because he's 80 doesn't mean that he's not fit for chemo. At a very minimum, you should be considering doublet with ADT plus ARSI. And again, not a doublet with ADT chemotherapy alone.
Makes me wonder if this gentleman has been hypogonadal for a long period of time.
From what reason?
Because the ARV7 splice variants, they don't they don't tend to just generate de novo.
No, I'm saying, why would they be hypogonadal from what?
I don't know.
I mean, what causes you to be hypogonadal?
Lots of things, stress, I don't know, like a lot of different things can cause people. With age, people can become hypogonadal, so.
Pituitary, I mean, vehicle?
I mean, I think it, you know, I want not to say the aging process, but I wonder if maybe he had some, I don't know, distant history of some sort of chemotherapy that he received a while before for some other thing, or maybe he has some condition that he was on steroids for something, you know. But I think the state of makes me wonder what's happening to this gentleman's hormone axis, that he developed an ARV7 splice variant.
So in terms of other unanswerable, well, maybe answerable, Emmanuel, you know, I was asking you this a few weeks ago. I'm still trying to figure it out. You know, Andy Armstrong from Duke, we were doing a program with him, and he said, you know, really prostate, I mean, I knew that BRCA2 was more common, but he was just kind of saying, like, you hardly ever see BRCA1. When he sees BRCA1, he doesn't even necessarily trust that it's true, and that, you know, it's very different. It sounds totally different than breast, ovary, everything else. Is that right?
It is. You know, in breast and ovary, there's about a 50-50 split between BRCA1 and BRCA2 that totals about 10 to 12%. In prostate, the total is also 10 to 12%, but it's a 10-to-1 ratio favoring BRCA2 and not BRCA1. And the second issue is if you have a germline BRCA1 mutation, it's not clear whether those carriers of the germline BRCA1, when they get prostate cancer, if their prostate cancer is driven by the germline mutation or if it's a sporadic. And the way that you can figure that out is you can look for the second allele in the tumor and see if it's mutated. In most cases, it's not.
And Emmanuel is going to talk about that as part of his talk, but just again to throw in a clinical question to you, Rana. In a patient with metastatic prostate cancer, any situation, what do you consider a minimal workup to look for the possibility of giving a PARP? How do you do it? Do you do germline first? Do you do somatic? Do you do them both?
So I do both. I do both a germline test, I do a somatic test. I tend to do my somatic test at the time that they're diagnosed. So this is a gentleman with metastatic disease. I won't wait until they get into CRPC to do the test. I like doing it up front with their fresh tissue to help me plan ahead and see what's going on. I may repeat the test again after they've been exposed to various treatments and are developing progression, because we know that people can acquire mutations in the DNA repair pathway. They may not start out with them de novo. I think the preference is to use tissue for the somatic tumor profiling, but understanding there can be limitations with availability of tissue in these patients that have bone mets. I think the split has been kind of like 70-30, like 70% of the time we're able to get tissue, and then the remaining you kind of use a ctDNA test, understanding the limitations, because with ctDNA testing you have trouble detecting gene losses, so there can be false negatives in the context of that.
All right, Emmanuel, you had a lot to cover. I'm really curious where things are with lutetium as well, and I know you're going to talk about that too.
All right, I'll stay on time, Neil. So I'm going to talk about PARP inhibitors and lutetium PSMA disclosures. And this is a real case, African-American man, 58 at diagnosis. His mother and sister both died of breast cancer in their 30s. So there's a hint there of a genetic component. Underwent prostatectomy, developed lung metastases as an isolated site, no bone disease. Received ADT plus docetaxel. This was about 5 years ago now, where that was a standard of care. And then developed progression only in the lung, interestingly, without bone disease. And some questions here for the audience. You don't have to answer them, but just think it through. What would you do in this situation? And the key here, of course, is that he tested positive for a germline pathogenic BRCA2. We'll never know if his mom and sister had the same thing. They probably did. So he would be an ideal candidate for either PARP inhibitor monotherapy or combination with ARSI. I actually liked Rana's slide better. I think mine's a little bit too complicated, but the key is that we have at least 2 genetically targeted therapies where we are informed by next generation sequencing or the presence of PSMA cell surface marker. Quickly talking about the incidence of homologous recombination repair mutations. Nice, easy rule to remember. 25% of patients with metastatic disease will have a somatic mutation in one of these genes, mainly BRCA2, and then 12% will have an inherited mutation. In both cases, BRCA2 is the most common. This is my list of relevant HRR genes. You're not going to find this in a textbook. It's probably controversial. It's the Antonarakis list. The list on the left, first tier, are the ones that have the best response, in my opinion, to PARP inhibitors. And then as we move on to the right-hand side, these are the other so-called HRR genes that we have not seen much success with, and their prevalences. Germline and somatic testing is outlined in the NCCN guidelines. It's getting more and more confusing. Every patient with metastatic disease should undergo both germline and somatic. And then the germline component should also be offered to all patients with high-risk localized disease as well, and the intermediate risk and low-risk patients who have family histories of cancer. How do you test? Rana covered this briefly. My first choice is metastatic tumor biopsy. Second choice, if that's not available, is ctDNA. Third choice is an archival biopsy, including the prostatectomy itself, if that's available. And then fourth and least desirable is germline-only testing. If you do that, you're going to miss the somatic alterations if you only look at the germline. So let's talk about PARP inhibitors. How do they work? They work because of this concept called synthetic lethality. It means that you have to wipe out single-strand DNA repair and double-strand repair. This is now well known from breast cancer, ovarian cancer. These are the 4 PARP inhibitors that have FDA approvals in prostate cancer. That's pretty remarkable that we've now outpaced even breast cancer with our PARP inhibitors, and we are allowing somatic mutation testing, not just germline mutation testing for eligibility. Talazoparib probably is the best PARP trapper and also the greatest enzymatic inhibitor of the PARP1 enzyme, so it's the strongest one. So in May 2020, 3 days apart, we had monotherapy approvals for olaparib monotherapy for 14 HRR genes shown on the small print, and then rucaparib was approved also as a monotherapy for just BRCA1 and BRCA2. Now this talk is going to focus on the combinations, but keep those 2 approvals in mind. The combinations are in combination with androgen receptor targeting therapies. There's 3 trials, the PROPEL, Magnitude, and TALAPRO. If you look at the right-hand side with the parentheses, PROPEL and Magnitude led to FDA approvals only in BRCA1 and BRCA2, so I'm starting with the punchline and working backwards. TALAPRO-2 has a 12-gene approval, companion diagnostic, and they are listed there. Starting with PROPEL, this was in first-line mCRPC patients. They could have received docetaxel in the hormone-sensitive setting, but they didn't have to. Then they were randomized to abiraterone plus or minus olaparib. RPFS was primary endpoint. Genomically unselected patients here, that's the key. And then a post-hoc analysis of the biomarker positive and biomarker negative groups. Study overall was positive, but the FDA approval did not follow the primary endpoint. So the FDA approval went to an ODAC committee. It was quite controversial. And then the approval was for a narrow population of BRCA1 and BRCA2 altered patients. It was about 90 patients. It was a tiny subset. Again, not pre-specified post-hoc, and yet the FDA felt that that was where the data was the most compelling. Magnitude did have a selection. There was a biomarker positive and negative cohort. Here it was niraparib combined with abiraterone versus abiraterone alone. The biomarker negative population was closed early for futility. The biomarker positive population showed a benefit in the entire HRR panel shown on the top. This is a PFS benefit, and a greater degree of benefit in the BRCA1 and BRCA mutated group. This FDA approval also chose to focus on only the BRCA1/2 subset, so not the entire panel of genes. Again, that's niraparib plus abiraterone. And then finally, talazoparib plus enzalutamide. This is, again, first-line mCRPC. Prior chemotherapy in the hormone-sensitive setting was allowed. No prior enzalutamide. Randomized to enza or enza plus talazoparib. Here there were 2 cohorts, all-comer cohort 1 and then a DDR positive cohort 2. And in the overall cohort, primary endpoint RPFS significant, but again, the greater difference was driven by those patients that had the HRR deficient and specifically BRCA1 and 2 deficient. In this trial, the FDA approved the combination of tala plus enzalutamide in all 12 genes that were included in the eligibility. So this goes beyond BRCA1 and BRCA2. The adverse events are not identical, although they're overlapping, so cytopenias occur in all 3. Pulmonary embolism, 7% with PROPEL, olaparib plus abiraterone, that stands out. And then transfusion requirements, a quarter to a third of patients need to have at least 1 red blood cell transfusion. That is not insignificant. That occurs more so with tala, enza, and niraparib, abiraterone. Now, lutetium, PSMA, vipivotide, dextrazetan, 2 studies here. The VISION trial, which was a third-line study, post-AR, post-taxane, and then the PSMA-4 study, which was post-AR, pre-taxane. PSMA, you're going to like this, Neil. I call it pretty specific membrane antigen. It's not really prostate specific. It's expressed on the salivary glands, the lacrimal glands, and the renal vasculature. So dry mouth, dry eye, and potentially nephrotoxicity are things that we need to look out for. It's a cell surface receptor. The drug is a radioligand. What does that mean? It's a ligand to the receptor, and the ligand includes a radioactive beta-emitting radiopharmaceutical called lutetium-177. It gets internalized by the PSMA-positive cell, releases the radioactivity, the beta particles kill the cancer cell. This was the phase 3 trial led by Oliver Sartor and Michael Morris, presented at plenary session and subsequent New England Journal. Second to third line, post-AR, post-taxane chemotherapy. The control arm here was basically best supportive care. Chemotherapy was excluded from this. That was a bit controversial, or the lutetium PSMA. PSMA CT PET scans were required. There was an 86% positivity. So most patients are going to have a positive PSMA PET scan, 86%. And then those that were positive went on to receive the treatment or the best supportive care. There was a big PFS and OS advantage, again, including overall survival. You can see hazard ratio 0.62. That's a very respectable OS. Again, keeping in mind the control arm was basically a supportive care rather than, for example, cabazitaxel. Now, if you look at the New England Journal publication, dry mouth, 30 to 40%, it can be significant. Dry eyes was not listed on this table, but it does occur. And again, you can see cytopenias. In this trial, every patient had received docetaxel. So when you use this drug prior to taxane chemotherapy, the cytopenias are less. Exactly 2 years ago today, exactly 2 years, March 23rd, 2022, it was FDA approved. There was a bit of a lag because of production issues. It was only being produced in European locations. Now we have a United States manufacturing plants. It's rolling out into the community. Right now, mainly in academic centers. It's either given by nuclear medicine, radiation oncologists, mainly NUCMED at the moment. Most people have to come to academic sites. It's an intravenous injection given once every 6 weeks for a total of 6 doses. Now the PSMA-4, it's before chemotherapy. So this was post-AR targeting therapy, pre-chemotherapy, and here the control arm was the ARPI switch. So if a patient had received abiraterone, they either got lutetium, pre-chemotherapy, or the alternative enzalutamide, and vice versa. Primary endpoint, radiographic progression-free survival. In this trial, 92% PSMA positivity. So the earlier you go, the greater the chance that you're going to have a PSMA positive as opposed to PSMA negative cancer. And this trial allowed crossover. People on the control arm who got the alternative ARSI were able to cross over to get lutetium PSMA 617. The RPFS is not affected by the crossover. So this RPFS was very significant, doubling radiographic progression from 6 months to 12 months, hazard ratio very respectable, 0.43, upper limit 0.54. No question that this is benefiting patients. However, here's the controversy. Overall survival, yes, there was 84% of patients who crossed over. However, look at this. There isn't even a suggestion of a trend. In fact, hazard ratio is above 1 rather than below 1. So this has not received FDA approval yet in the pre-chemotherapy setting. Yes, it has activity, but does it improve survival when you use it early versus late? The jury is out. And it may not improve survival when you use it early versus late. You may still get the same benefit if it's given later. So that's controversial, my own editorial comments there. I think I'm on time, Neil. Germline and somatic DNA repair mutations should be tested in all metastatic castration-resistant patients. Homologous repair mutations sensitized to PARP inhibitors. We've got 2 monotherapy approvals, olaparib and rucaparib. We've got olaparib and niraparib in combination with abiraterone, again, only for BRCA1 and BRCA2. We also have talazoparib in combination with enzalutamide for a series of 12 genes, including but not restricted to BRCA1 and 2. Moving on to lutetium PSMA, it's expressed in more than 80% of patients, close to 90% when you're looking at the pre-chemotherapy CRPC patients. Currently only approved in the third-line setting. So if you have a patient today who has not received the taxane in any setting, it's going to be very difficult for you to get access to lutetium PSMA that may change with the results of the PSMA-4.
So just a couple of quick questions before we conclude, before we go for a break. And Susmitha, I'll go to you in a second. But Rana, in patients with bone-only Mets, what comes first, lutetium or radium?
I think that probably leaning more towards lutetium than radium in that context, just because of its activity in all sites of disease, whether you can see it, when you don't. Radium is largely treating the microenvironment.
Susmitha?
My question would be going back to the same patient. He just developed localized recurrence in the left perineum, which was excised because it was a lot of pain for him. So how would you treat this patient now? Would you do just SBRT and monitor? He's been off of enzalutamide for more than 6 months. Would you re-challenge him with enzalutamide or another agent? You have already answered my question about the lutetium. That was my other question. Or would you start this patient on chemotherapy plus, because he really does not have any significant disease volume?
Emmanuel?
If I understood correctly, if he's had a resection of his local recurrence in the perineum, no evidence of other disease, I would wait unless his PSA begins to rise.
Yes.
And then I would treat him as a BCR patient with, ADT plus or minus enzalutamide. I would not give chemotherapy for this patient.
Okay.
Final question to Rana. How do you prevent or manage dry mouth with lutetium?
So I think, in my experience, actually the dry mouth hasn't been the worst of the symptoms that people experience. It's been contending with the thrombocytopenia and nausea. I think the biggest thing to help patients with dry mouth is actually a stash of Werther's Originals or other sort of sucking candies to keep their mouth moist. The artificial saliva, mixed reviews on that because it can cause this kind of film in people's mouths, but encouraging people to stay hydrated and sucking candies are great.
So thanks to the three of you, particularly Rana, for your heroic effort to get here. I cannot believe you actually did all that. I mean, a couple hours late and the whole thing would have gone, but it totally works.
It worked out. Thanks
destiny. You were destined to be here, and we really
be here back in
believe
Florida.
it. All right, we're going to
Thank
take
you.
a quick break, and we'll come back talking about lung cancer.